In 2024, the Biden administration proposed expanding Medicare and Medicaid coverage to include GLP-1s. These drugs, as you know, were originally developed for diabetes and are now widely prescribed for obesity and have been positioned as the potential inflection point in chronic disease prevention. In other words, they're amazing. Now, in April 2025, which was like this month, the Trump administration formally rejected the proposal. The decision has triggered a predictable response: public concern over access, equity, and cost containment. I got into several arguments on X, my favorite platform. But this case, perhaps more than any other in recent years, reveals the structural limits of publicly administered healthcare in managing innovation at scale, something many of you don't know one thing about. Let's begin with basic economics. The cost of a GLP-1 medication ranges from $900 to $1,400 per month when purchased at retail. Assuming a moderate uptake across Medicare and Medicaid, analysts estimate an extra $40 billion in federal spending over the next decade. Some long-term models project total liabilities exceeding $3 trillion when including future eligibility, inflationary pricing, and extended duration of therapy. In other words, nobody's getting off these drugs. Now, this isn't merely a budgetary concern. It's also an architectural one. Medicare, as currently structured, is not equipped to contain costs for high-demand, high-cost drugs. And it doesn't negotiate list prices. Under the Medicare Modernization Act of 2003, the federal government is expressly prohibited from negotiating prices with manufacturers. Instead, the function is delegated to private PBMs who negotiate on behalf of Part D plans. But those incentives are misaligned with cost containment. Pharmaceutical firms set the list price, PBMs negotiate formulary access, and, of course, they extract the rebates. Medicare pays the net price without visibility into either. I mean, it's a disaster. This arrangement, of course, is designed under the assumption that the private sector intermediaries would drive efficiency. It does if you have morals, but it doesn't if you don't. Now, so the result is a system in which the large healthcare buyer in the United States lacks the true purchasing leverage. Now consider the alternative mechanisms emerging in the private market. That's the market I like, by the way. Compounding pharmacies have begun offering semaglutide formulations for $100 to $500 a month. These are legally produced under the FDA exemptions, particularly where drug shortages exist. While compounded medications carry certain clinical risks, they demonstrate an essential point. Pricing is not a function of cost, but of structure. When competition is permitted and cash markets emerge, prices drop precipitously. When intermediaries dominate, reimbursements the default, prices rise. This case is not fundamentally about whether GLP-1s are medically effective. That point's largely settled. This is about how and through which vehicle access should be delivered and financed. Pay attention. To expand Medicare coverage for these drugs, current pricing rules would exacerbate financial strain and entrench an unsustainable model. It would create political pressure to cover additional lifestyle and preventative drugs in the future without addressing any root cause of price escalation. In contrast, market-driven models, particularly those built on direct contracting between employers, physicians, vendors, offers price discipline, supply chain flexibility, and demand-side accountability. These are features not available in a single-payer system. In short, the rejection of GLP-1 coverage by Medicare is not a denial of treatment. It's not a denial of treatment. It's an implicit acknowledgement of Medicare's inability to manage price and access simultaneously. There is a policy decision to be made here, but it must be made with a full recognition of Medicare's limitations. If the United States intends to expand access to high-cost medications, it has to reform the structure that sets the prices, not simply reallocate the liability. GLP-1s are a test, not of medical effectiveness, but how we govern healthcare in an age of innovation. Some of you are going to have to watch this on like 3-peat, 4-peat, 5-peat so you begin to understand. Stop arguing with me. I'm right.
Let me make this real simple. Healthcare is broken. Bloated systems, overpriced services, no transparency. Everybody knows it. Now you can continue to complain about it or you can invest in fixing it. FICAP Fund is where independent physicians, operators, and rebels put capital behind startups that are actually solving the mess. No slow bureaucracies, no legacy thinking, just bold execution and asymmetric returns. You want access to the deals that don't make it to the mainstream? You want your dollars building the future of healthcare, not funding the problem? Then stop scrolling and start asking about FICAP Fund. Because the next unicorn in healthcare isn't coming from a health system. It's coming from the outside. This is venture with a mission. This is FICAP Fund. DM Invest for more information. Info@ficap.com.